Achromatopsia. And our next speaker is Dr. Hertle, who's the Chief of Pediatric Ophthalmology and Vision Center at the Akron Children's Hospital. And the title of his talk is Visual Ocular Motor Consequences and Treatment of the Ocular Motor System 17 Patients with Achromatopsia. Dr. Hertle.
Good afternoon. Let me turn my video, make sure my video is on. Okay. It's a pleasure to be part of this symposium. I always enjoy not only participating, but hearing all of the other excellent scientific talks. I'm going to spend a few minutes summarizing our experience with the treatment of a rare form of retinal genetic disease affecting the cones. And this is called achromatopsia or dyschromatopsia. And I'm sorry. My computer is operating itself. Nice. Let's start again. The first slide here shows these children have intense blepharospasm and photophobia, and here's a child before and here's a child after treatment. And this is what the world looks a little bit like to them. They have some dyschromatopsia, especially on the blue-yellow axis. And this is a rare disease occurring in about 1 in 30,000. It's inherited in autosomal recessive fashion. These are the common clinical characteristics. I'm not going to read all these, but I do want to point out some of the characteristics that are important for our discussion today, in that all of these patients have nystagmus, or the infantile nystagmus syndrome. The special testing that's performed in many places on almost all of these patients you see on the second section here. We also indeed perform eye movement recordings on these patients, and we also treat these patients with optical, medical, and surgical treatment. So this data is from a prospective database that we collect on all our patients with nystagmus, and they routinely get the special testing that you see here. And the VEP is for visual evoked response, optical coherence tomography, photos, color vision testing, and contrast sensitivity function. Non-routine testing that occurs in older children and adults could include visual fields, corneal topographies, central nervous system testing. In addition, if there are additional systemic or central nervous system signs or symptoms, and laboratory, and now we've incorporated routine genetic testing in almost all of our patients. And we do treat these patients with combinations of medical, optical, and surgical treatments. And this is mostly for strabismus. This is a typical slide of an OCT of patient with achromatopsia, showing the disturbance in the outer segments of the retina, particularly the rod and ellipsoid zone. These are the operations that we perform in patients with nystagmus. This is an algorithm we put together as a result of operating on thousands of patients with nystagmus. And in our 17 patients, you can see the numbers of patients that have had these procedures. 13 of the 17 have had surgery for a chin down head posture, which reflects an up gaze, eccentric gaze null associated with infantile nystagmus. The 17 patients who are the subjects of this study are the result of evaluation of over 1,700 patients with nystagmus from 38 states and 30 countries, which is why I think we can get a lot of these patients with rare diseases. You can see some of their characteristics, but what I wanted to concentrate on here was the ocular motor characteristics, and that 100% of these patients have infantile nystagmus syndrome, and almost all of them have a very peculiar waveform called a dual jerk waveform, which is an abnormality of the slow phase seen here. They don't have vergent stamping. They don't get better when their eyes converge, and they don't have a latent component present in about 40 to 50% of patients with INS, which can make them look like they have fusion maldevelopment nystagmus syndrome, when in fact they have infantile nystagmus syndrome, and they don't have periodicity, or that's a spontaneous change in direction or intensity. About 40% had amblyopia, mostly from strabismic, anisometropic, or mixed. And almost all of them had a head posture, predominantly chin down. This is just a collage of eye movement recordings in the 17 patients. It's not meant to go over in detail, just to show you that these dual jerk waveforms are present in almost every single patient. And these are a multi-oscillation on top of the slow phase. These are the acuities that are done in these patients. We do binocular best acuity in their correction, pre and post-operatively. We use single surrounded HOTV optitized matching or matching plus verbal, like the PEDIG protocol. And this shows that they have terrible vision, these patients in general. They average, as you can see here, 2280 before surgery. But after eye muscle surgery, and this is eye muscle surgery alone, it was a significant improvement, almost a full logMAR line, which was significant to 2180 as a group. And this is an example of what the patients look like before and after. You can see this patient's very difficult for her to fixate. She has intense blepharospasm and photophobia. And then this is about, the bottom picture is about 6 months after surgery, showing a visibly reduced nystagmus amount, much improved ability to fixate, follow, and a decreased blepharospasm. The anomalous chin down position is also corrected with the combination surgery that we pointed out earlier. And here's an example of pre and post-op eye movement recordings showing the drastic decrease in the dual jerk component on the slow phase, even though the overall intensity was about the same. One of the things that we measure in these patients, because we think this is a better measurement of visual outcome, is contrast sensitivity. And this shows that at the lower contrast, in this particular, we use the CSV 1000, at the lower cycles per degree stimuli, there's an improvement. At the higher cycles per degree, where there's higher contrast, they don't improve that much. In our large group of infantile nystagmus population patients who don't have significant afferent system disease, there's improvements across the board in contrast sensitivity, but we find this only at the lower cycles per degree or at the less levels of contrast that are seen here in the testing. So what we found from this is that the particular waveform associated with this form of inherited retinal disease is a dual jerk infantile nystagmus syndrome. They have a predominant upgaze eccentric null position, which is also common in albinism, interestingly, another form of afferent system disease affecting the retina and or optic nerve. And that eye muscle surgery itself, as we've shown in many other forms of infantile nystagmus syndrome associated with afferent system disease, there you see improvements in binocular high spatial frequency vision as manifested by checking letters. You see improvement in contrast. The head posture gets better. The nystagmus improves. And one of the interesting findings here is their ability to tolerate light. Blepharospasm gets better as well. This dual jerk waveform is very particular in that it may be due to interruptions in the nucleus of the optic tract. And thanks for allowing me to share this with you in this short period of time.
Thank you, Dr. Hertle. I see no questions in the chat, so I'll just start off. We've just had two great talks on eye movement and diagnosis of eye movement. How early can you diagnose these children, and does it matter when you do the surgery? Is it better to do it earlier than later?
So we can diagnose, we can do eye movement recordings at birth. Okay. The evolution of infantile nystagmus syndrome has a characteristic change from early infancy to later. Infantile nystagmus syndrome is acquired between the first 1 and 3 months of age. And there is a change in waveform that goes from a largely pendular, asymmetric pendulum to increasing jerk. So the eye movement abnormality can be diagnosed extremely early. And any intervention in a developmental problem, it's better to intervene early. When do we teach our children to speak, to do sports, to learn instruments? The earlier that we teach them, the better. So intervention in a developing brain is always better. We have data showing that patients under 2 respond better than patients over 2, and I have data showing under 8 responds better as well. But generally, the earlier the better. I recommend that these kids have surgery somewhere between 10 and 18 months of age, usually when they get on their feet. For the previous decades, the traditional time to do surgery was either never, which still happens, or between after 7 to 10 years of age, and only if they have a constant head posture, which these kids don't, because eventually they give it up because they can't maintain it all the time. They have to choose. Do I see better, feel better, see better, or feel better? And they choose to feel better. So from the clinician standpoint, the null position goes away. But if you record them as adults or older children, they still have the null position. They just don't use it as much.
Thank you, Dr. Hertle.